Greetings to you all from IAP KOTTAYAM and ICH. And we are here, as you all know, this evening for the PG Club. It is a prestigious program of IAP Kerala. And this evening from ICH, we are presenting one case. And this is the third batch of students, postgraduate students, who are getting benefit out of the PG Club program. That's an online program. And this evening, from our department, we are coming out with a rare case, which was not that rare in the past, but still, for us, that is a rare case. And I'm not going into the details of the case. And I'm here to welcome you all for the PG Club. And at the outset, I would like to thank my IAP Kottayam office bearers and also the coordinators of the PG Club program for giving me this chance to welcome you all for this program. First of all, let me welcome our state IAP President, Dr. Shimmi Paulos, to this meeting. Don't know whether sir has joined or not. Then
Very much joined.
Professor Mohandas sir is the state coordinator of this program. Though we are the conductor of this program, and formally I will extend a hearty welcome to this program. And Dr. Ananda Keshavan, it's no introduction to this forum, and he's the scientific convener of the particular PG Club. Sir, I extend you a hearty welcome and best wishes for your candidature. Today, the discussant is Professor Bindusha from Government Medical College, Thrissur. I extend you a hearty welcome. And the mentor of the particular student is Professor Cyril Ignatius Rosario. I extend a hearty welcome to you. Then presenter is Dr. Ajesha, our third year junior resident. I welcome you and wish you the best for today's discussion. And I would like to welcome all the office bearers of the IAP, then senior teachers like Purushothaman sir, Vijay sir was there, then the faculty members, IAP members, and the residents for this meeting. Once again, I welcome one and all for this PG Club. Thank you.
Next, I invite Mohandas sir, State Coordinator of PG Club IAP Kerala, to say a few words.
Thank you, Dr. Thomas Varghese, who is the zonal coordinator of this program, for arranging this in a beautiful manner. I'm very happy to be part of this program. It is a great opportunity both for the faculty and also for the postgraduate students in our area. And I would like to congratulate IAP Kottayam, headed by Dr. Bala, Dr. Sumita, and Sahala, for arranging this week's program. And I would like to place my special thanks to Dr. Bindusha, who agreed to be the discussant, even though I had asked her only very few days prior. And again, Dr. Cyril, who is the mentor of this program, who is a best friend of mine. And I would like to I'm very happy to see a lot of our faculty and postgraduate students to be here. Thank you.
I request Shimmi sir to say a few words.
Thank you, Dr. Thomas. Our scientific convener for the program, Dr. Ananda Keshavan sir, the state coordinator, Dr. Mohandas sir, and the faculty for today's meeting, as well as the zonal coordinator, Dr. Thomas, and Dali Madam, Purushothaman sir, and definitely Dr. Bindusha, Dr. Cyril, and the presenter for today, Dr. Ajesha. Warm welcoming for everybody to this program. And of course, the PG Club program has been going on very well, and a lot of active participation is there from the PGs as well as from the members itself. I think so. Our academicians are really well. But similar program on the same date, we are not able to hold it even at 9:30 because the discussion is so So nice to see that it is going well. And I should really congratulate
related issues പഠിക്കണതല്ലേ
our
പേഴ്സണാലിറ്റി ഒന്നും
PG
നമുക്കറിയില്ല.
club coordinator as well as the chairperson for having taken it in a good way, and also the coordinators, the zonal coordinators for organizing it in a very good way. So wishing the program all the best and happy learning for each and everyone. Thank you.
Anandayashan sir.
Very good evening, respected State President Dr. Shimi sir, Program Coordinator Dr. Mohandas sir, Dr. Putsham sir, Darli madam, and our old HOD Dr. Cyril, and also Dr. Bindusha, and also even I think we can see faculty from outside Kerala also, Dr. Ramesh Bajania, EB board member and past national president of EC Environment chapter president. Dr. Bajani sir, welcome, and also all my dear sir.
Good evening, sir. Thank you so much.
Yeah, this program is going very smoothly under the leadership of Dr. Mohandas sir, and also the backbone of the program. I think I have to say that is the zonal coordinator. They are doing very wonderful program, very efficiently, and I think students, more students should attend, because now I think teachers are more than the students anyway. I think more will join, and the program is going very in a wonderful way. I wish the program all the best, all success. And Darling madam called some rare case, and we have an excellent teacher, Bindusha. So we are waiting for the excellent scientific session. Thank you. Jai Hind, IAP.
Next is introduction of speaker and presenter by myself. Today's discussant is Dr. Bindusha S. Madam, as we all know, Madam is an excellent and very friendly teacher. She's my own teacher. She's a professor and she's a professor of Department of Pediatrics, Government Medical College, Thrissur. And Madam authored many chapters in different textbooks like PG textbooks of pediatrics, IAP management protocol, Bavin's textbook of adolescent pediatrics, Pearls in pediatrics, textbook of allergy, asthma, immunology, and also Madam is the academic editor of SAT treatment guidelines for sick children, and also Madam is editor of Handbook of Pediatrics. And today's presenter is our own junior resident, third year junior resident, Dr. Ajisha Xavier. She is third year JR ICH coordinator. Welcome you, madam, and also welcome Ajisha for the. And we can next I invite Cyril sir, mentor, for introducing the case.
Respected teachers, colleagues, and PGs, we are happy to present a case of pseudo-paralysis, where the suggestion from the radiologist helped us to make a definite diagnosis. I'm not going into details of the case. Dr. Ajisha, third year JR, will be presenting the case in detail. Thank you.
So, madam, we can start the discussion. Ajisha, you can present the case.
Jayesha is not seen.
Actually,
That
I
name
think
is not seen.
Jayesha lost her connection.
He's not seen.
Ajisha, ഉണ്ടല്ലോ എന്താ?
Yes, he has come.
Ajisha.
He's joined.
I would like to thank the IAP Kerala and IAP Kottayam for giving this opportunity, and also the PG club coordinators for this for inviting me to be a part of this program. Let us move on to Ajisha. You can start presenting, Ajisha.
Thank you, ma'am.
Slide share ചെയ്ത് Ajisha.
Slide share. PG club.
ആർക്കും ഷെയർ ചെയ്തിട്ടുണ്ടാ?
Dr. Ajesha, okay. Now it's okay.
Okay, sir. Thank you, sir. Respected teacher, senior faculty, and dear friends, good evening. I'm here to present the case of Master A 4-year-old child, boy child from Kottayam, a date admitted here on 28th of May 2024 and examined on 2nd of June 2024. The information was given by mother and the history is reliable. He presented with complaints of difficulty in walking for 1.5 month duration, bleeding from gums for 1 month, swelling and pain of both knees for 3 weeks, pain while micturition for 2 days, and fever for 1 day. History of present illness. The child was apparently normal till 1.5 months back when he developed difficulty in walking, which was of insidious onset, slowly progressive, and it was associated with pain in the thighs and legs. At the onset of difficulty in walking, he was able to walk for a short distance within the room, despite the presence of pain. The child also had associated pain over his legs while standing, and he was able to stand upright for a few minutes despite the presence of pain. He is unable to climb upstairs and has difficulty in climbing downstairs. He used to drag his legs down to get downstairs at the onset of the symptoms, which he wasn't able to perform later. He was able to sit up from the... Madam. He was able to sit up from the lying posture with his own support and was also able to get on his knees. History of limping noticed while walking by the parents. He also had difficulty in squatting. There is no history of difficulty in raising the legs while lying down, and there is no history of pain in the hips. There is no history of swaying to sides while walking, and no history of unsteadiness of the head or body while sitting. And 2 days after the onset of these symptoms, he consulted at a local hospital, from where X-ray of both legs and hip were taken, and it was told to be normal. From there, certain blood investigations were done, and it was also told to be normal, and he was managed conservatively with paracetamol according to his mother. 4 days later, his leg pain increased, and he was now unable to walk even for a few minutes, which he was able to do earlier. So they consulted ICH. I evaluated here, and an auto consultation was sought. He was told to have some problem related to the muscle and was managed with paracetamol, topical gel application, and hot fomentation, and was advised to review after 2-week duration. Following these, pain improved and he was able to stand up for a few minutes and would now bear weight on his knees as well. 2 weeks later, that is after stopping the medications, his pain reappeared and it started increasing and was again unable to stand and walk. But he was able to pursue hot and cold temperature. There's no history in lifting up the hand, or he was able to feed by self. There's no history of frequent falls, no history of buckling of knees while walking. There is no history of slippage of slippers or difficulty in wearing slippers. There is no history of diplopia, blurring of vision, or abnormal eye movements. There's no history of asymmetry of the face while laughing or crying or drooling of saliva. There's no history of difficulty in eye closure, no history of nasal regurgitation or nasal twang to voice, no history of trauma to limbs, no history of abnormal limb posturing, no history of hair loss or abnormal sweating over the legs, no history of breathing difficulty or abnormal movements. No history of fever, no history of recent intramuscular injections or immunization, no history of recent respiratory tract infection or diarrheal diseases. And the child also had bleeding from gums for past 1 month. It was noticed while brushing teeth and it was of fresh bleeding. He also had swelling over the jaws, over the gums, which was present over both upper and lower gums. It was more on the right upper side. It was associated with pain over the swelling. There was also history of dental caries, which was noticed in the right upper teeth, for which they consulted a dentist and was treated with oral antibiotics, paracetamol, and was advised dental hygiene and cold compresses with ice, following which the swelling and bleeding reduced. There is no history of abnormal discoloration over the gums, no history of staining of teeth, no history of petechiae or ecchymosis. There's no history of prolonged bleeding from injury sites or swelling over the vaccination site. There's no history of recurrent swelling over the knees, no history of prominence over the chest wall, no history of drug intake other than the recent intake of paracetamol, no history of generalized tiredness, palpitations, or breathing difficulty, no history of recurrent infections. And then the child then developed swelling over both his knees, which was present for the past 3 weeks. It was also of insidious onset and slowly progressive, associated with pain over the swelling. Swelling is present persistently, and it was present diffusely over the knees and extending up to the legs. And it was soft to touch with associated pain and warmth. Pain and warmth on touching. It was of continuous pain. There's no radiation of the pain, no history of particular aggravating or relieving factors. There's no sleep disturbances due to pain. They consulted at a local hospital for which he was advised bed rest, but as symptoms persisted and the swelling increased over the past 4 days with restriction of movements around the knees. And now the child prefers to keep his knees in a flexed position. There's no history of trauma, swelling, pain over other joints, swelling of digits. There's no history of associated night pains or bone pains. No history of joint stiffness. No history of chronic cough, sore throat, diarrhea, or weight loss. No history of backache. No history of redness of the eyes or visual disturbances. No history of rashes, nodules, swelling over the bony prominences or urticaria. No history of nail changes or oral ulcerations. No history of diarrhea or abdominal pain. Following this, he also had pain while micturition for the past 2 days, which was associated with seeing cola-colored urine. There is no history of increased frequency of micturition, no history of dribbling or urgency, no history of abdominal pain, no history of pus discharge, periurethra or local trauma, no history of facial or leg edema, no history of abdominal pain or distension of abdomen or constipation. Then he developed fever for 1 day duration, which was of insidious onset, intermittent and low-grade fever, which was subsiding with paracetamol. No history of associated chills or rigor. No history of eye discharge, cough or associated rash. And then with these symptoms, the child was admitted at ICH Kottayam, was evaluated for the above symptoms. Blood investigations had revealed anemia, for which he was started on oral supplementation. X-ray of the knee was taken, which also showed some abnormality and was started on oral medication. Urine examination was told to be abnormal with some growth of organism and treated with IV medications. After 1 week of starting treatment, the swelling over the knees and pain reduced, and he was now able to sit up with his own support and could stand for a few minutes.
Okay, Ajisha, you have described the history. Let us discuss the history of present illness, then we will move on. Okay, right.
Okay, madam.
So you have described the history of present illness in detail. This is a 3-year-old child who first presented with pain in the lower limbs. Right. Then when a child is coming to you with pain in the lower limbs, what are your what are the things that you need to think about?
Madam, in this age group, he's a 4-year-old boy child. Yeah. So in this age group, growing pains is one of the possibility.
Okay. What are the typical clinical features of growing pain?
Growing pain, usually the pain increases towards the evening, and the child will ask the parents to massage the limbs, and following this, the pain disappears, and the next morning, the child wakes up without any pain.
Okay, child should be all right in the next morning. Okay.
Yes.
Here the pain was persisting, right?
Yes, madam. Then the possibilities, if there is a history of preceding fever, viral myositis is another common problem, which the child may be presenting with. Then pain over the limbs, it could also be due to some infection of the musculoskeletal system, like an osteomyelitis of the bone.
Yes.
The child may be, in that case, the child will be having high-grade fever.
Yeah.
So he will also be unable to move his limbs, might present a pseudo-paralysis.
Then.
And associated swelling may be there over the joints also.
Okay. There was no swelling or anything in the first presentation. The child only had pain and the child had difficulty in walking. Was the difficulty in walking due to some weakness, or is it due to pain only?
Madam, from the history, it is like it was due to pain because he was able to lift up the legs while he was in lying down posture. He was unable to bear weight because of the pain.
He was not able to bear weight due to the pain. There was no pain or movement of the upper limbs at all. Upper limbs are completely spared, right?
Yes, madam. And there is no other neurological features like no cranial nerves are not involved.
Then over the past 1.5 months, this progress. Was there any period during which the child had some relief, not when the child was taking paracetamol?
Other child had relief only he was on paracetamol. Otherwise, he was symptomatic
He was.
over the past 1.5
Okay.
months.
Then over the past 1.5 months, child developed multiple problems like arthritis. I mean, it may be an arthritis, there was swelling of the knees, and the child also bleeding from the gums, pain during maturation and all. Huh? So considering all these things, what do you think from the history that the child is having? What is his problem?
Child has difficulty in walking with.
What were the first impression?
First impression is, madam, because there is arthritis with bleeding manifestations and also colour urine, which is also suggestive of passing blood in urine. So bleeding manifestations with arthritis in this age group, I should consider the possibility of malignancy, hematological malignancy like leukemia, infiltration.
Yes.
Then arthritis
leukemia and
with
also
hematuria.
neuroblastoma can present like this, right?
Yes,
What is the point against the diagnosis of leukemia in this child from the history? Is there any point against the diagnosis of leukemia?
There is no other bleeding manifestations. And child is, there's no associated weight loss or fatigue.
Yeah,
there is no bone pains.
no fever
There is
also,
no night pains.
right?
Just 1 day history of
Fever
fever.
was in
was
the
there.
last episode. Okay.
Then considering arthritis with hematuria, there's a possibility of henoch-Schondin purpura, which is also fitting in this age group. Then
What's the point
considering
against the diagnosis of HSP?
there's no abdominal pain, there's no palpable purpura, there's no rashes.
Okay.
Sorry.
Then will you think about any other connective tissue problems, any other rheumatological problems in this child?
Bleeding gums with hypertrophy and presenting a pseudoparalysis, a possibility of nutritional cause.
Okay,
could also be considered.
Also, yeah. Then. Will you consider diagnosis of JA?
JA because age group is fitting, but the duration is only 3 weeks, so it can be an evolving JIA. So it may, the child has to be followed up for 6 weeks.
Yeah. If it is a JA, what is the type of JA that you think about?
It is the oligoarticular JA because
okay,
only
we need
2
to consider
joints are
oligoarticular JA also, but the swelling of the knees, that is arthritis, is only for 3 weeks. So you will not be able to say that is a JA now. It may be an evolving JA also. That also need to be considered, but the child is having a bleeding tendency also, right?
So, madam, another possibility is that considering he's a boy child, age group of 4 years, swelling of the knee joint with associated bleeding manifestations, hemophilia is a possibility, but that can be down in the list.
Yeah.
Because there's
okay, being a boy child and hemarthrosis of the knees, you need to consider this hemophilia also. But the other things like difficulty in walking, everything is actually pain while maturation. All those things are against the diagnosis of hemophilia. So these were the things that you were considering in the front when you are assessing the history of the present illness, right? Okay. Now we can continue.
Okay. Past history, there's no history of similar illness in the past. There's no history of previous hospitalizations, no history of previous blood or blood product transfusion, no history of recurrent swellings over the knees. He's not on any medications other than the recent intake of paracetamol. Antenatal history is the second child of non-consanguineous parents, conceived normally. Age of mother at conception was 29 years and of father was 33 years. had regular antenatal checkups, and she's booked and immunized. Pregnancy detected by UPT after 1 month of amenorrhea. The history of hyperemesis requiring hospitalization and IV fluids. Folic acid tablets were taken post-conceptionally, and there's history of hypothyroidism in mother, and she was on thyroxine 50 microgram. Quickening was felt at 5th month, and she continued to pursue fetal movements well. Iron and calcium tablets were taken. Dating scan and anomaly scan were normal. Growth scan revealed oligohydramnios, but there was no fetal growth restriction. There's no history of gestational diabetes mellitus or gestational hypertension. There's no history of bleeding per vaginum, fever, rashes, drug intake, premature rupture of membranes, or urinary tract infections. Natal history. He was born as a term by emergency LSS in view of previous cesarean section with fetal distress at a general hospital Tripunithira with a birth weight of 2.4 kg. He's a low birth weight baby. Postnatal period of the baby cried soon after birth and he was breastfed within 1 hour, passed urine and meconium in 24 hours. There's no history of NICU admission and was discharged on 5th postnatal day. Developmental history, his gross motor, fine motor, and socio-adaptive milestones are appropriate for age. Language, he speaks only 2-word sentence with a developmental quotient of 48%, developmental age corresponding to 2 years. Hearing and vision are normal. There's isolated language delay in this child. Madam, may I proceed with this?
Yes.
Diet history, he was exclusively breastfed till 6 months and is continuing to breastfeed now. He's given breastfeeds once at night time for about half an hour. Complementary feeds were started at 6 months with Ragi. He was on family pot feeding from 1 year of age. Based on 24-hour recall, this is his diet. He consumes his diet consists mostly of bakery items like pakavada, biscuits, cakes, and fried items. He consumes breakfast dosha 1 or 2 dosha per day and lunch rice only half cup. And most of the days, a mother gives a history that he used to skip his lunch and dinner. So based on the 24-hour recall, the inference was that his deficit to 401.5 kilocalories, but protein requirement is adequate. He is deficient in micronutrients, vitamins, iron, and calcium.
Okay, can you analyze that diet? Which are the micronutrients which is likely to be deficient in this child?
Madam, this child, he doesn't consume any vegetables, fruits.
Yes.
So most of the vitamins are deficient in this child.
Yeah.
Especially vitamin A, C, and B complex vitamins are grossly deficient in this child. And he doesn't consume any milk or milk products other than the breast milk. So he's more prone for calcium deficiency. And also because he consumes meat and meat products only once or twice in a week, and also deficient in green leafy vegetables. He is prone to be iron deficient also.
Okay, which are the micronutrient deficiency which are of public health importance? All the micronutrient deficiencies are important, but which do have a greater public health importance?
Vitamin A is of public health importance.
Yeah.
Then iodine deficiency.
Vitamin A?
Iodine deficiency, madam.
Iodine, yeah. Then?
Vitamin D.
No, it's iron and zinc. Okay. Iron, zinc, vitamin A, and iodine. These are the 4 micronutrients which have micronutrient deficiency, which have global public health importance. Okay. Have you heard about hidden hunger index? What is that? What is hidden hunger?
That's pertaining to micronutrient deficiency.
Yeah, hidden hunger is a name which is used to represent the micronutrient deficiency. Okay. So what is hidden hunger index? Hidden hunger index is something, it's an index which is used to analyze the micronutrient deficiency. It is based upon 3 micronutrients: zinc, iron, and one more, that is vitamin A. These are the three micronutrients which are considered into the hidden hunger index. Hidden hunger index is usually assessed in this age group, toddler age group, preschool children, and also in the young children. they are in this age group, if the hidden hunger index is high, that indicates that the country as such has more of micronutrient malnutrition. Okay. So zinc is used for as a surrogate marker for stunting. If the country is having more children with stunting, that indicates that the country is zinc deficient. And vitamin A is considered as a surrogate marker for immunity, and iron for physical capability and also also cognition. That is why these three elements are assessed. They actually don't measure the blood level for all these nutrients. They measure the blood levels only for vitamin A. For zinc, you measure the amount of children, you find out the amount of children with number of children with stunting. And for iron, you just look at the prevalence of anemia. By looking at these three macronutrient deficiency status, and these three macronutrient deficiency states, they are given equal importance, and by that you can calculate the hidden hunger index. That is how we analyze the micronutrient deficiency status of a country as such. It's not for the individual patient or anything, it's for the for assessing the micronutrient status of the country and to compare with the other countries. Okay. So these here the child can, from analyzing this patient, we can see that the child can have multiple micronutrient deficiency. Yeah? And there is very less amount of vegetables. There is no fruits at all. And then even the meat items, everything is less. And you said that the child is having. Can we move on to the next slide?
Yes, madam.
Here you said that the child is having adequate protein intake. That is 17.75 grams of protein. Is it adequate actually? Should you consider anything else other than the amount when you say that the protein is adequate? Should you consider anything else?
The quality of protein
Yeah,
and the
the
net
quality of the protein should
utilization.
also be considered. Suppose you are getting 10 grams of protein from fish or egg, and another child is getting 10 grams of protein from rice alone, then the quality is different. Even though the amount is same, the quality is different. So in order to say that the patient is getting good, adequate amount of protein, you need to say, you need to analyze into the quality also. Usually, when we say that food is if a food item is a good source of protein, that takes into account the quality also. Okay. Can you tell me some indicators by which you can assess the protein quality?
Net protein utilization.
Yes. They were the old one. Then we actually studied about the net protein utilization, digestibility quotient, and all. Nowadays, they use two indices, which are not two amino acid scores, which will consider both the protein digestibility and also the amount of proportion of indispensable or essential amino acids in a protein. They are known as protein digestibility corrected amino acid score and digestible indispensable amino acid score. You don't have to know about those, but usually PDCAS or protein digestibility corrected amino acid score is the one which is used to express the protein quality. That has to be you have to multiply the amount of protein in a substance with the PDCAS. PDCAS of most of the non-vegetarian proteins, that is meat, fish, egg, milk, all those are one. So there won't be any correction factor. But when you come to the rice protein, it will be 0.2. When you look at the pulse protein, it may be 0.4. So all the food items have different PDCAS. So you have to do that also, because this is a patient who has multiple deficiencies. So even though this child is having adequate protein, you need to go. I actually don't know whether this patient is having adequate protein or not. Because before we say that the child is having adequate protein, especially in this child, you will have to go into the details of the quality of the protein before you say that. Okay. And do you think that this child, why is the child not getting adequate diversity or variety in the diet? Is it because the parents are not able to procure or anything, or is it due to some eating problem? What do you think so?
It's basically because of the eating trouble of the child. In the toddler age group children, they're usually prone to they're usually prone to be less interested in food items because they are more interested in exploring the environment and more interested in playing and all. So they don't care much about the food items.
Okay, what you meant to say is that after 1 year of age, children will have a physiological anorexia, right? Because till 1 year, the growth rate also is high. So the child will actually eat more. And after 1 year, the growth rate decreases and the activity increases. They'll be more interested in surroundings. So they will have a little bit decrease in the amount of food intake when you compare with an infant. That is then anything else? So you're thinking only that this child only has been physiological anorexia?
Also, there are certain problems like fussy eaters or the picky eaters and infantile anorexia related issues among the toddlers.
Okay, so what do you mean by a picky eater?
Picky eaters is that those children, they're not much interested in food. They're not interested in trying new foods. They eat only a very little amount of food and they take a longer time to eat the food. So that may result in a lower weight gain and growth faltering. But as the toddlers become school-going age group, they overgrow these issues.
They usually overgrow it. And is it very usual for these children with picky eating to develop what you call nutrient deficiencies? Micronutrient deficiency diseases and also malnutrition, stunting, wasting, all those things. Is it very usual for these picky eaters to develop those conditions?
And they're actually more prone to develop micronutrients because they tend to avoid vegetable items. So they're more prone for micronutrient deficiencies and they are usually interested in snacks items. So the calories they get from those. So
what happens is they will eat some of the food items, depending upon the color, texture, or anything. Usually, what happens is they will avoid the fruits, vegetables, and all. So they are more prone to develop micronutrient deficiencies. But sometimes, if it is very severe, there may be some involvement of the growth also. But usually, they won't present you with an acute malnutrition or anything. They usually have only mild, minimal impairment of the weight, and they may have micronutrient malabsorption because usually most of these children will be able to meet their energy needs because they actually have some craving for carbohydrates, so they will eat some as you described. They will eat some snacks so that they will have adequate calories. Here also you can see that the calories are a little bit deficient here. There is some calorie deficiencies also there. And this is not an acute problem. The child never had a good eating habit, right?
Yes, madam.
Okay. Can you say tell me any other eating problems which can present you with even malnutrition, wasting and all?
That's another eating disorder among children like avoidant restrictive food intake disorders.
Okay,
So
what
they
is that?
They usually present with growth faltering, low weight, and associated micronutrient deficiencies. So in this case, organic causes has to be ruled out.
Yeah, that is a severe eating disorder. Okay, there you need to look for you need to find out whether the child is having any organic cause which is interfering with the eating. Yeah? And usually these children will require supplement to maintain their normal health. Okay, unlike the what you call picky eater, where they may have only micronutrient deficiency. Okay, can you do anything to overcome this picky eating?
Positive reinforcement behavior, motivating the child to eat new foods, like a new food item have to be introduced some 10 to 15 times for the child to accept it. The positive parenting behaviors might help the child. So once the child eats the new item, he could be encouraged and motivated to continue the same and rewarded.
Yes, very good. And also another thing is the family in eating along with the family. Don't make any special food for the child alone. And the child also has to be involved in the preparation of the food, procuring the food from the supermarket or from the vegetable seller and all, the child has to be involved with that, and child has to be involved in the preparation of the food and all, so that the child will be interested in eating that. So all those things can be advised to the mother. It's not only that you just need to tell the mother how to make, what is the type of food to be eaten, what is the amount to be eaten, you need to particular food also. Okay.
Madam, may I proceed?
So
Madam, may I
we
proceed?
can continue.
Okay, madam.
Addition.
Immunization. Immunization history. He is immunized up to age as per national immunization schedule. No additional vaccines taken. Vitamin E, 7 doses were taken. No history of adverse events following immunization. BCG score was present. Family history. He is the second born child of non-consanguineous parents. Age of mother is 33 years and father 37 years. He has an elder sibling, 11-year-old girl child, who is developmentally normal and is studying in 6th standard. There's no family history of malignancies, joint deformities, tuberculosis, or contact with TB among family members. No history of bleeding disorders or requirement of blood transfusion among family members. Socioeconomic status. This is a 5-member family, joint family. Father has studied up to 10th standard and he's doing painting works. Mother has studied up to DMLT and she's a homemaker. They have a Pakka house with water source being from Panchayat supply. They use boiled water for drinking. Sanitary latrine is present, and according to modified Kuppasamy scale, they belong to upper lower scale. A summary. This is a 4-year-old developmentally normal and immunized for aged child with nil significant past of family history with dietary deficiency of micronutrients, presented with an acute onset of additive symmetric arthritis involving both knees with pseudoparalysis, with no associated deformity, with history of gum bleeding and gross hematuria, has isolated speech delay with there's no associated bleeding manifestations or rash, other than for hematuria and bleeding gums. Shall I proceed with
Okay,
the
here,
examination?
do you want to modify your differential diagnosis after your completing the history?
After completing the history, I think nutritional cause could be put on the first differential
It should
diagnosis.
also be considered. Maybe we cannot say that it should be the first diagnosis, but it should also be considered in your differential diagnosis. Okay.
Shall I proceed, madam?
Is there anything else to be discussed?
Ajisha,
Purushottam sir?
Ajisha, in
sir.
the history, when you present the history to an audience, always be very slow. Because your presentation was really fast, it was difficult to follow for the first time because a lot of points, the person who are hearing, you should give some time for thinking. So it was a reading, it should not be reading. So the voice modulation is important. It need not be uniformly slow. So imagine the person who is hearing. So present slowly so that we'll be analyzing. Okay. Some of these things can be faster, some of them slower. Our voice modulation is important. So that we'll consider and go in an unbiased manner. Previously, normal boy child, 4 years, for the last 1.5 months only this problem. Without fever, the limping, so trauma is important. So I think you didn't give much stress to the trauma part.
She said there is no trauma.
There's no.
But it was in the.
That should be mentioned because in this baby it may not be possible, but one of the situations in another situation is a battered babies in type of situations are likely that need to be considered. The parent may not be having complaint. So trauma is one of the possibilities. And a little more details about the activities, and you should have been trying the to pinpoint where exactly is the problem in this. Because from what you said, there was a problem, the right knee joint part. That's what I got. Okay.
Both knees.
It was a little
Okay.
problem because out of the many differential diagnoses, you consider myositis and all. So it can be outright excluded because myositis always be bilateral. And it will be involving other parts also. So one unilateral thing will help to rule out many possibilities. It's unilateral, then where exactly is it? Is it in the joint or not in the joint? A joint problem and a bone problem. If it is a joint problem, is it in the knee or hip? You might have heard referred pain. Pain in the hip referred to the knee. So just because a 4-year-old child is pointing to the knee, don't jump to the conclusion that there's a knee point problem. The hip also need to be. So what all activities, so a little more of this previous video and a recent video would have been helpful. And what all things are affected, whether in between the period, child was able to sit and play, a toilet using. So those are the points which will be helping how much the movement is possible at different joints. The sitting during the toilet, which toilet she was using, European. So 4-year-old child is unlikely to be using a European. Maybe another one. So which toilet she are using and whether she is able to sit. And a 4-year-old child will be sitting and playing. So whether she is not doing like that or always she won't be in the dining table or this thing. So sitting, how much it's affected? Because hip and knee will definitely are needed in the sitting part. So what is the affection there? If that is not affected, there's a possibility of the same problem in the bone also. There are different diagnoses, are many. You consider the malignancies, of course. You consider the connective tissue disorders. You consider the scurvy, which is a rare entity. So before you diagnose a rare entity as a first, you should be doubly cautious. In this case, there is no fever, there is no weight loss. There are many points against the malignancies, but still malignancy can behave like that. So keep in mind most of the other possibilities like CRMO and all. The connective tissue disorders where it is not a joint problem, it's in the bone problem. So cystic lesions, osteoma like situation also can be possible. So wider possibilities are there for this thing. A little more effort should have been there to pinpoint where exactly is the point. Pain. Okay. Activity restriction and a video would have been helpful. And the next thing is about the urinary part. You said the color-colored urine. And a little more about the urinary, the micturition, other parts. Whether there was any other voiding disturbance, because there can be a problem of lymphoma and all, NHL and all, that can be presenting in the pelvis and urinary disturbance can occur due to that. So is it a discoloration only? Is it other disturbances? What was the stream like? Was there anything other than the stream incontinence or initiation or frequency? So that urinary problems also need to be asked. So a little more of the history needed. Otherwise, all the things are, when out of the family history, some rare possibility of a sickle cell disorder, sickle cell anemia. But in this case, unlikely, but you need to consider that also is a possibility. Okay. Otherwise, the history is. Does anything to anything else you want to tell? Does?
I also thought what you were saying, first we should try to analyze where exactly is the problem is, and also try to differentiate whether it is a neurological problem or some other problem. That I think she has done properly. And okay, the same comments.
Okay.
You can continue, Ajisha.
Okay. General examination. The child is alert. He was lying in bed with both knees kept partially flexed. There was mild pallor. There's no icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy. Vitals, pulse rate was 120 per minute, rhythm was regular, volume was normal and normal character. All peripheral pulses were felt equally, and there is no radioradial or radiofemoral delay. Blood pressure was 106 by 68 millimeter mercury, measured in the right upper limb in supine position. Respiratory rate is 22 per minute and was abdominothoracic type. Temperature was 98.6 degree Fahrenheit and saturation was 100% in room air. Head to foot examination. The head appears normal in size and shape. There is no facial dysmorphism. In eyes, there is no conjunctivitis, uveitis, bitoid spots, telangiectasia, no edema or redness or rash around the eyelids. Nose, it's normal. There's no deformity. Ears appeared normal. Oral cavity, there was generalized gum hypertrophy. No fresh bleeds noted. No discoloration of the gums. There was a localized mass arising from the gums about 2 into 1.5 centimeter, which was present over the right upper gum margins. Dental care is noted in the right upper molars with gingivitis. There's no glossitis, anglocheilitis, or oral ulcerations. Chest, there is no costochondral prominences, Harrison's sulcus, pectus excavatum, or carinatum. Abdomen was normal. Extremities, there was edema present in both knees. There's no widening at the wrists. Fingers and toes normal. There was mild hyperpigmentation of the knuckles. No nail changes. Spine appeared normal. Hair also appeared normal. There was no alopecia. No skin rashes. It was male external genitalia and bilateral testes were descended. Anthropometry. Weight of the child is 12.6 kg against an expected of 16. It was between -2 and -3 standard deviation with moderate underweight. Height for age was 92 centimeter and expected 103 between -2 and -3 standard deviation with moderate stunting. Mid upper arm circumference was 14 centimeter and it was normal. Head circumference was 49 centimeter and normal. Weight for height was also normal. There's no wasting. Growth charts depicting the weight for age, which fall below -2 and -3, and length for age also between -2 and -3. Weight for height between 0 and -1, which was normal. Head circumference was also normal. And the child's height for age was below -2 standard deviation, so short stature is there. And calculating the mid-parental height, his height velocity lies within the mid-parental height. Systemic examination.
Ajisha, go back.
Sir.
The parameters, anthropometric parameters are important because this anthropometry indicates it's not an acute problem, long duration problem.
Long duration.
Weight and height are affected less than 3 standard.
Both are affected.
Then you mid-parental. Mid-parental is in the third standard, maybe for the height acceptable, but the weight is significantly affected. So weight also you can't say it is because the parents are small. Weight also it is less than third standard. So that much of weight you said it's not lost during this short period. So that need to be given importance. And what is the weightage? 12.6 means the weightage is significantly.
Weightage is around
2 years.
Weightage is around 2 years, 2 months.
So
weightage is most affected.
There is no past history of any significant illness. Weightage is affected.
No, sir.
Don't be in the impression that just because the parents are in the third centile for the height, child also will be in the third centile for the weight. So there need to be some explanation. So your concept of the nutritional part about the proteins and all comes here. So the excess is it the protein quality? So calories deficient is the protein excess, but it's not possible. So that is one point. In the general examination, if you're a head to foot examination, in the peripheral pulse, important, all the peripheral pulse you mentioned is normal. BP also need to be mentioned in the lower limb because you need in the pain, rarely there can be some vasculitis of the major descending aorta and all, presenting with claudication type of pain. it may not be giving much of evidences unless you measure the BP in the lower limb. Typical history of claudication need to be asked. So BP of all the limbs are important. About the facial mass, that is a little more important. More view is important. Is it a gum hypertrophy? Only a little more mass is there. So that is a totally different thing which you are not expecting with the so far history. Okay. Go ahead.
Can you describe about the link with the gingiva?
Bindusha, one very important point you have mentioned. I was also thinking about the quality of the protein part. We are not teaching anywhere in the postgraduates and undergraduates. So people, subspecialty nutrition should be including that point in the teaching. So we all stop with the calorie deficit, protein deficit. We are not going in depth about the quality of proteins, indices. That is a very important valid point to be included in the at least the PG history. How much is the source of protein constituted by the animal source and the plant source and the quality indices? That's an important point. I learned lesson from you. Thank you.
Ajisha, can you describe about the swelling inside the gingiva? What was that actually? I think she lost her connection again. Ajisha is just,
Madam?
there is no slides seen now. Okay, now we can see.
Yes, okay. About the gingival swelling, there is generalized hypertrophy of the gums involving both the upper and the lower jaw. But there is a localized swelling over the right upper jaw, about 2 into 1 centimeter. And there is also dental caries. So it could probably because of dental caries and secondary to it, the gingivitis.
So do you think this is the
Dental
periodontal abscess? It doesn't look like an abscess actually. Right, because it's actually inside the gums, inside the alveolar margin, you're seeing that swelling, right?
Right, madam.
Was it bleeding, that swelling?
No, madam. While examination, there was no bleeding from the
No
swelling.
bleeding. Was it tender?
It was a mild pain was there. On deep palpation, there was pain.
So what happened to that swelling? It's still persisting there?
No, madam. On follow-up, the child came after 3 weeks. The swelling has reduced.
Because I'm not happy with that. You just moved on with that swelling. You showed the picture. What we are interested is just like a dentist, as a surgeon, we should be trying to answer a few questions. For a pediatrician or a physician, what we all know is the gingival hypertrophy of scurvy and leukemia. Okay. But that is not fitting with it. You are getting a swelling which is much within the palatal part. So it cannot be related to caries tooth complication also because the teeth part is normal. So alveolar abscess is the one thing which will lead to. It cannot be explained. So is it involving, is it arising the palate? In that situation, what we are interested is, what about, is it a tender on palpation? What about the other part of the palate? Is the sinus normal? So just like any dentist examining, we also can do that. So we should not be happy with and move on. Okay.
The consistency also, I think it is important.
Okay. So don't move on with possibilities because we are seeing the kids just like any super specialist. We should also try to analyze. So it's a little bit odd when we are characterizing it's a scurvy-like thing or a leukemia. Both I am not happy. So there must be something more than that. Okay. And after giving the antibiotic, is it responding? Okay. Go ahead. Ajisha, go ahead.
Okay, sir. Systemic examination, examination of the musculoskeletal system, P-GALT screening. Again, because of pain, the child was unable to stand up and he was unable to walk. Arms was normal. Legs, there was arthritis involving both knees. Spine, normal. And examination of knees, both knees, the child was examined lying in bed and his knees were kept in partially flexed posture. Inspection, there was edema present in both knees, no erythema, skin change over the swelling, no muscle wasting noted, no joint deformity. On palpation, there was warmth and tenderness of both joints, and there was minimal effusion noted in both knees. It was present right side, effusion was more than on the left side. There is no joint line tenderness. Range of movements was restricted. Both flexion and extension were restricted. Examination of other system, central nervous system, higher mental function, speech, cranial nerves, motor system were normal. Reflexes, deep tendon reflexes, superficial reflexes, normal. A sensory system, normal. No cerebellar signs. There's no signs of meningeal irritation. Skull and spine appeared normal. Other systemic examination were also within normal limit. Summary. This is a 4-year-old developmentally
What
normal
about
child.
other joints?
No other joints are involved. Only the knees, only both right and left knees were
Okay, all
involved.
other movements had normal range of movement, no tenderness, no swelling, nothing was there.
Nothing was there, only other than for these.
What about spine?
Spine was also normal, madam. There is no spine tenderness.
Adisha, in the examination of the knee, again, that is the time when you are answering the basic question. Is it a joint problem or a bone problem? The attitude of the joint is kept in the flexed position, both the knee. The question is, in a knee joint or an outside pathology, what about the appearance of the knee? Is the fullness of the areas. If it is a synovial joint, synovial effusion is there, you will get the front of this thing filled up. So filling, and it is over all the sides. Then the movement will be resident in all the movements. If it is the recession of one movement only, there is no effusion part involving the whole side, then it can be sometimes a local pathology is like your back only involvement is possible. So localized or general arthritis is the examination you are ruling out. That examination is important. Of course, in this case, you have postulated that it must be joint pathology itself. Then a lot more in the general examination stressed. What about the lymph node? Did you look for all the lymph nodes?
There is no.
That
no
is important in this case. And as Dr. Bindusha suggested, what about the other part? The pelvis, the spine, ribs, scapulae, skull. Because there are many disorders like that. The malignant, it's an eosinophilic, this thing, Langerhans cell disorders. Okay, they're all important. So other areas of the bone and joint, it's not just P-GALS only. The skull palpation is important. There can be lytic lesions which unless you palpate the skull, you will be missing. The spine tenderness, the pelvis is important. Sternal tenderness is important. So general examination, a lot more points are important. Okay. And movements of the hip joint, especially in this case. So you said that knee joint movement is restricted. So we are interested about the hip joint also. Okay. In this case, a knee, bilateral knee only. Okay.
Both knees are affected.
Looking from the distance in the photograph, the skin seems to be very shiny throughout. It's not only the knee. Is there a generalized the edema spreading down to the legs also, leg part also, or is it apparent from the photo?
So there was swelling only around the knees, sir.
Okay.
Localized to the knees, sir.
Both knee involvement is there clinically.
Yes, sir.
Hip and other joints are spared.
Spared, sir.
You look for all the small joints.
Yes, sir. Small joints were also looked for. There was no swelling or tenderness, sir.
No other tenderness in the other areas also.
No tenderness in other areas, sir.
It's very important in this case. That's why.
Yes.
Okay.
Moving on with the summary. This is a 4-year-old developmentally normal child and immunized for each boy child with nil significant past or family history, with micronutrient deficiency and anthropometry revealing moderate underweight and moderate stunting, who presented with acute additive symmetric inflammatory oligoarthritis of large joints with functional limitation, pseudoparalysis with no deformities, with associated bleeding and hypertrophy of the gums and gross hematuria without any organomegaly or generalized lymphadenopathy. The diagnosis is acute symmetric large joint oligoarthritis with pseudoparalysis, gross hematuria, probably due to urinary tract infection, mild anemia probably nutritional, moderate underweight and moderate stunting with short stature, probably nutritional with isolated speech delay. The differential diagnosis considered are malignancy, leukemias, nutritional, osteomyelitis being the infective cause, hemophilic arthritis, and an evolving juvenile idiopathic arthritis.
Okay, why did you consider osteomyelitis as your second diagnosis?
Madam, osteomyelitis.
And from your examination, you're saying that this is mainly arthritis.
Arthritis. Because it can also present as pseudoparalysis and arthritis, maybe septic arthritis of the joint can spread on to involve the bones and present as osteomyelitis.
Bilateral symmetrical osteomyelitis.
Symmetrical, that is a point which is less favoring.
Okay. Okay, nutritional, scurvy, hemophilic, and JA. Okay, other things we discussed there. Right?
Yes.
So, how are you planning to move on?
So this
How
child,
do you want to?
Anisha, I think number 1 and number 5. Malignancy and JIA.
Involving JA.
Osteomyelitis is almost out.
Yes,
Because no fever situation involving bilateral. So don't put that as a major possibility. If at all, CRMO is one possibility. CRMO, chronic recurrent multifocal osteomyelitis. But in this case, you said it is in the joint, within the joint. So it's very, very unlikely. So you can, that goes on the 5th position. Nutritional scurvy, even though it's a rare entity, so I won't put that top in the list. Juvenile idiopathic arthritis definitely will be number 2. Hemophilia, okay, possible. Okay. So osteomyelitis should be the last. Nutrition also, okay, it will be the 4th one. Okay, that will be my order of possibilities.
Can you consider a reactive arthritis?
Yes, madam. Considering the age group and the duration, it usually presents within 3 days to 6 weeks of prior onset of a diarrheal disease or a respiratory infection. Here, the point against is that there is no past history of genitourinary or enteropathic infection. And the favoring points are that the reactive arthritis usually involves the large joints and also the lower limb joints. Those are the favoring points. So that
What
can
about
also
post-infectious arthritis?
Post-infectious arthritis, that also there's no past history of fever or recent infection.
I could follow a viral infection. There is no history of any even mild fever, upper respiratory infection, nothing is there.
In case of, there is no history of rash also.
Okay. In post-infectious arthritis, there need not be any rash. It usually follows a viral infections. A lot of viral infections can lead on to post-infectious arthritis. Rubella, mumps, varicella, even hepatitis. All those a lot of viral infections can produce post-infectious arthritis. That is a differential diagnosis of the reactive arthritis. Reactive arthritis typically, the reactive arthritis per se is the one which is following the urinary infection or the infection. And post-infectious is other infections which will present you with a reactive arthritis, like which you call it post-infection. That is the only difference. Okay. So I think we can consider that one also, because this is a short history. Only three weeks duration of arthritis. We need to consider reactive or post-infectious arthritis also in the list. Then instead of osteomyelitis, we can put that then your differential diagnosis will be there. So how are you planning to evaluate this child?
Instead, we have done a basic blood counts, which is shown as this severe anemia. HB was only 6.7, and it was of microcytic hypochromic type. MCV, MCH, and MCH all were on the lower side. RBC and red cell distribution width was within normal limits. There was also elevated inflammatory markers like both CRP and ESR were elevated.
Just one thing, MCV 70.3. Don't go with the impression that it is too low, because normal is for a 22-year-old child, it is a normal. 70 is normal. After that, age plus 1. Okay. So by 10 years only, you expect a 80. 80. Okay, normal 80. Don't consider it's too low. Maybe 72 or 73 will be the normal for this age group. So 70 is not that micro for this 4-year-old child. Okay. So that is the reason why your RDW is not wide. Okay. So it may not be nutritional alone. That is a very important point, because with the nutritional history 6.7, you are likely to brand it as a nutritional anemia, but it is unlikely. Even though your MCV is 70.3, RDW is normal, so there must be another reason for that pallor. Okay.
Serum calcium and phosphorus were 8.3 and 5.1, almost normal. Vitamin D3 was in the insufficient level. RFT, ferritin, thyroid function test, and LDH were normal. Urine return revealed plenty of RBCs, and culture revealed Klebsiella growth. Peripheral smear showed normocytic normochromic anemia with few microcytic hypochromic cells. And vitamin B12 was done because there was a mild hyperpigmentation of the knuckles, and considering the dietary history and the anthropometry values, deficiency was considered and it was done, which came to be lower. And then X-ray of knees were done.
Previous slides on the hematological. First slide. The very, very important when you get you need to give importance to all these things. We are considering malignancy as a different diagnosis. So platelet 1.6. That's a very important thing. So what is the importance? We are considering malignancy. The platelet is normal here.
Normal here. So
platelet is actually towards the higher side.
That
indicate?
I think it's more towards inflammatory cause.
Okay.
What else? What other conditions? What other situations? Simple situations where you get a platelet little on the higher side. Iron deficiency.
Here.
Even though I said iron deficiency per se is not a major reason, but there can be a little contribution. Okay. So platelet can be a little on the higher side if the anemia is iron deficiency. But this low hemoglobin, what is the normal hemoglobin expected? Just say.
More than 11.5.
So anything less than 11 is 6.7 is a significant anemia.
Severe anemia.
For the significant anemia, you don't have an explanation by iron deficiency, because RDW is normal and 70.3 is not that microscopic anemia. But the platelet count is a little on the higher side. Or whether it is explainable by hyperchromic microcytic anemia, otherwise it points to some other reason for a high platelet. So platelet is to be analyzed. Okay. And there you need the ESR and CRP. So CRP, it's not, is that significant rise in the CRP?
No, sir, just elevated, moderately elevated.
So isn't that important?
Yes, sir.
Because you are considering possibilities of a
Malignancy also here.
Malignancy. So there comes a importance of that. Don't move on without the analysis. Okay. JIA situation also we are considering. There again, important.
Yes, sir.
So connective tissue disorders and malignancies, this is not that supporting. Okay. CRP is not that high. What is the other thing in this case? Needed LDH also.
LDH.
Okay. So LDH also is needed. The ferritin.
LDH is done.
Okay.
LDH is within 300 normal, sir.
Within normal. So
Within normal.
now your first possibility goes down in the list. So till now, clinically, you are considering malignancy or other connectivities are top in the list. With the first investigation, they move down in the list. Okay. So this is a very important slide. Ferritin.
Ferritin was normal, so it was 88.2.
So your argument of a iron
Deficiency
goes down in the list. Okay. LDH is 314 only. Okay. RBC plenty, microhematuria is there. Okay. Culture clubs.
Now you're having a urinary tract infection also, right?
Right. Okay, go on. Peripheral smear, what was the finding? Peripheral smear?
It should normocytic normochromic anemia with few microcytic hypochromic cells.
Okay.
And then X-ray of the knees was done. So,
right.
X-ray of the knees, it showed area of calcification, that is the Frankel white line of calcification with the radiolucent zone just below the calcified zone, that is the traumafied zone, with a ring epiphysis and a spur pointing out the Pulcan spur. These features were suggestive of vitamin C deficiency is curvy.
Very typical.
So, but vitamin C level done, which came out to be normal. So this was the ultrasound of the knee which was done.
Was it before giving vitamin C?
Yes, sir, it was done before starting vitamin C.
And before vitamin C, whenever you are sending an investigations like folic acid, vitamin B12, vitamin C and all, you need to know the technique involved. There are many factors which will modify the results. False positive and false negative results are well known in all these things. Folic acid. So don't give much importance to the level. It's a treatable entity. Treat it. Ignore the result. Okay.
Yeah, it may be normal, and even in scurvy, it may be normal, right? You're supposed to measure the leukocyte vitamin C level, right? But that is available anywhere here. Okay, we can explain this one.
This is the ultrasound of the knee, and this is the marrow, and this shows the periosteal, subperiosteal area. Usually, the subperiosteal area will not be this visible because there's a collection. This black radiolucent area is visible, and the area beneath that whitish area, opaque area, that is the subperiosteal hemorrhage. So there is subperiosteal hemorrhage, and these points are favoring towards scurvy.
But this was not visible in the X-ray, right?
This is not that apparent in the X-ray because during active disease, subperiosteal hemorrhage may not be that evident in an X-ray.
If you take an X-ray during the follow-up, you may be able to see.
Yes,
right.
madam.
What is the second X-ray? There are two.
They are the both same X-rays, but taken just one day apart.
Do you have follow-up X-ray? Because subperiosteal hemorrhage is very markedly seen. That's a very good characteristic features.
Follow-up X-ray is not available, sir.
So when the patient comes up follow-up, we take an X-ray. Now you'll be able to demonstrate that. If there was any subperiosteal hemorrhage, there will be periosteal reaction. Everything will be prominent on the follow-up X-rays. Okay.
This is the video. Yeah. That's 1 month after the starting of treatment, they just forwarded us the video of the child. It was that.
It was not playing.
It's
Did you save that video in any other place you can play?
This.
This is 1 month later.
This is actually three weeks after starting treatment. The child was able to walk a few distance.
No deformity, nothing.
No deformity, nothing, sir.
Okay. Did you take the hand, shoulder, or anything, any other areas?
No, so only the walking video is available. And
X-ray,
1 week later, this was the video which was sent by the child. 1 week after the previous video, was able to climb and without any support,
that's
he was
very
able
good.
to do.
About the X-ray, I mean, in the other areas, the wrist and shoulder, did you take X-ray in the active phase?
X-rays of other areas, it was taken, sir. Of the wrist and skull X-ray was also taken, sir.
Actually, that area also showed the same findings. Okay. No fractures in any other areas. That's what I want to know.
No fractures, sir. No fractures.
We used to get this scurvy in bedridden kids with cerebral palsy and other things. In a very normal child, you don't expect that. That's why you consider it goes low in the analysis phase. Okay. So this is a lesson because with the picky eating, this is one thing possible. We learn what lessons daily. Okay.
So how did you treat him? What is the dose of vitamin C that you gave?
He was started on vitamin C at 250 milligram. It was given twice daily. That is total 500 milligram. That has to be continued for 3 months.
Did you give any initial parental dose?
No, sir. Parental dose wasn't given. Because when we give
What
IV
about
dose,
the other deficiencies?
Vitamin B12 deficiency. Vitamin B12 deficiency was there. We have started supplementing vitamin B12 also. And vitamin D3 was on the insufficient level, which he has already taken vitamin D supplements on an OP basis.
Okay. Is there any relationship between iron deficiency and vitamin C?
Madam, vitamin C actually it helps to improve the absorption of iron.
Yes.
So vitamin C deficiency can cause iron deficiency also.
Only for the absorption, or is there any other action for vitamin C? Vitamin C is actually needed for the utilization of the iron also. For the RBC production, iron has to be utilized. For that also, vitamin C is needed. It's actually a part of a lot of enzymes. It's an antioxidant, right? So it's a part of a lot of enzymes, and in order to maintain there are a lot of metal enzymes in our body, right? So for all the metal enzymes to maintain the metal in the reduced stage, that is the active stage. For that, vitamin C is needed. So for hematopoiesis also, vitamin C is needed.
Also helps in folate, conversion of folate to tetrahydrofolate form.
Yeah. It has action on all the systems. It has action on immunity. Then collagen is the main one.
Yes,
then even for a critically ill child, vitamin C is supposed to be. There are studies which have supplemented vitamin C for sepsis and all, because it's needed for the production of neurotransmitters also. So it has varied function. This child only had the lower limb involvement. And also the gum involvement and bleeds. Right. No other no other problems. So in follow-up, did his hemoglobin improve?
It improved to 9, madam.
Okay. You were giving iron?
Yes, madam. Mine was also supplemented.
Okay, iron was also supplemented.
He was also asked to take citrus fruits, and dietary advice was also given.
And you were able to address his picky eating also?
Picky eating, while he was in the ward, to a certain extent, it was improved. He started eating 3 meals because usually he used to skip his lunch and breakfast. But while he was here, it was.
Yeah, that's an aspect that we need to address. Supplementation will only have short-term effect. And otherwise, if you don't address these eating habits, then after a few months or so, he may have other nutrient deficiencies. Anything else to add, sir?
Nothing. Mohandas, anything?
Can I add few points? One thing is my list of differential diagnosis will be, one is hematological malignancy, next will be scurvy, and third will be battered baby syndrome. So because most of the findings can be explained by that also. And in that case, in history, I think you should focus something on how is the bonding between the parents and the child, and any in examination also any marks suggestive of a battered baby syndrome, that will be better, I feel. And another, when you are considering scurvy, in the history, you could have highlighted that child is not eating any food, any uncooked food. Usually, scurvy is seen in children who don't eat anything uncooked. So, because it is a heat labile vitamin. And another thing is, when you are considering scurvy and you have seen the gum, the swelling, you should have mentioned whether it is spongy on palpation and whether there is any loosening of teeth also. That is another common association in scurvy. And also in the general exam, in the skin examination of the skin, perifollicular hemorrhage is said to be one association with the scurvy. And another thing is, since we are considering hematological malignancy, you should have highlighted whether there is any bone tenderness. These are some of the points which I thought is important.
Srinivasan sir undo. He has joined.
Sir, കഴിഞ്ഞ 2 ആഴ്ചയായിട്ട് കണ്ടില്ല.
കണ്ടില്ല അല്ലേ? Darli, anything more to add? Darli പോയോ?
Sir?
So nothing more.
Yes, Purushottam sir.
Actually, you can stop this screen share.
Okay, madam. Thank you.
We have seen scurvy mainly in children with cerebral palsy or other neurodevelopmental problems where they have a peculiar feeding pattern. They are given nothing uncooked. So that is the usual situation we see. And I have seen another child who had a diarrhea at 6 months, and mother thought that it is because of the uncooked food child is getting, and the germs will cause diarrhea if it is given uncooked. And she started giving everything cooked, including fruit juices or fruits. So in such a case, I have seen scurvy in otherwise normal child. It is very unusual to see this sort of case.
Interesting. CP children we have seen.
CP we have seen.
This is also very we haven't seen. And because of the clue given by the radiologist, we were able to help arrive at this diagnosis. Initially, clinically, we didn't suspect, to be honest.
And it highlights the importance of taking dietary history, not confining to the how much calorie, how much protein. Usually that is the only dietary history many students elicit. So if you consider all the aspects of the diet, probably this DD will come even before.
Nisha's question, what about the position of the situation of the gingival thing? Gums has recovered?
The gum hypertrophy has reduced. It hasn't completely recovered to normal, but the size has reduced.
Repeat X-ray was taken?
Repeat X-ray wasn't taken, sir. It was planned to be taken on next review, sir.
So what is the time period when it get normalizes, you know? How many weeks? 6 weeks.
Around 3 weeks, sir.
3 weeks it will be. Is there anything like just like vitamin D recovery? Showing the earliest thing is the zone of mineralization, calcium, like that. We don't have much experience with these rare disorders. So yesterday I was attending a conference of these infectious disease experts from different countries. And there was a very, very important point. Why should we follow CDC criteria for all? Because we are going to be there, we should be the expert. We see many of the communicable diseases they don't see. And we always go behind their thing. Just like that, these are all rare disorders which we see more. So we should be giving more importance to our own observations. So we should be recording scurvy, what happens on treatment. We learn and follow the Frankel's line, the Mattesper, this per, and all, and we keep on asking and going for the next description from them. Why we should, why we can't follow this case? What is the recovery pattern? What is the radiological changes on a scurvy with the vitamin C treatment? Because we are having enough of these nutrition deficiency, luckily, for the time being, all sort of micronutrient deficiency are common here. So we are the experts. So we should be recording all these things. So what is the pattern of the radiological change on treatment? So rather than doing it third week, is there any new change in the first week? So serially, because there is a little harm during this, minimal exposure, X-ray modification can be done and follow-up is needed. You get it in a rarely only. So ideally, this case is ideal for documenting that. You can report this case also, because there are reasons by which you should be reporting, because this has happened to a normal child. So, and these are a little bit of odd features in the ultrasonological thing, odd features also, and radiological features on treatment. That is an important point. Very good case. Anyway.
Can I ask one question to Ajesha?
Sir.
What is the reason for the saying, one apple a day keeps the doctor away?
It's rich in micronutrients.
Which micronutrient?
How that saying
B
came?
complex.
How that
vitamin C.
originated, that saying? Actually, this vitamin C and association with vitamin C and scurvy is considered as the first randomized control trial. So the sailors, when they go to the sea for months together, those who had apple with them, which will not perish that easily, that will last for months. So those who had apple with them, they did not develop scurvy. All others developed scurvy because they had no fruits available. So that is why the saying came that an apple a day keeps the doctor away.
Interesting point. During my student period, I was MBBS in the 70s. And during that period in IMCH Calicut, there was a ward for diarrhea, the different wards for all the communicable diseases. And there was a malnutrition ward also. So we're treating all sorts of all ranges of malnutrition, kwashiorkor. At that time, we didn't see scurvy. Scurvy, at that time, what we are taught, that is a rare thing. Even when all sorts of malnutrition, blindness, vitamin A, all sorts of deficiency were rampant at that time. Scurvy was not that common. Then scurvy I saw when I came in Thrissur and in 90s. That again, once in a while rare, that too in a cerebral palsy child or some other problem, chronically debilitated bedridden child. Very rarely only this sort of a normal child. So what is the reason? So at that time, the majority were poor. Invariably, they will be consuming some sort of green leafy and uncooked diet, I think. Now the pattern of diet has changed, and there is cooking pattern has changed, and the kids who are not taking some other thing, they'll be provided things without uncooked thing. So maybe the source of vitamin C in the present generation, even in the normal or picky eaters are all deficient. At that time, this was very unlikely to have a actual deficient vitamin C diet.
What is the cheapest source of vitamin C?
Indian amla, sir. Gooseberry.
It's not that cheap nowadays. Probably it is vitamin C tablets.
Yes.
What could be the reason for anemia in this case?
There is associated bleeding that could be a cause. Then vitamin C deficiency.
Bleeding
per
that
se,
significant to cause this much
no.
anemia?
Not that significant. That's one of the associated thing. Then vitamin C deficiency itself can cause poor iron absorption. Because there is gross.
If it is due to iron deficiency, we should expect a marked microcytosis.
It is normal.
RW should be high. The relatively normal MCV you can explain with the dimorphic anemia.
Okay.
Even in that case, RDW should be high. I don't know what exactly is the reason for this much severe anemia.
And so one more thing here, you need to look at the vitamin C status of the mother also. This baby, this child was getting breast milk even now, isn't it?
Yes,
Suppose the vitamin C status of the mother is normal, usually the child will get at least some amount of vitamin C from the breast milk. So make sure that the mother is also taking fruits and vegetables. Okay.
Okay, madam.
I think Adisha has done a very good job, and also I would like to congratulate the KOTTAYAM team for making a diagnosis of scurvy in this child, because this being a rare disease,
Really
we don't
interesting
usually
case.
think about scurvy. We will think about all the other things that we discussed. And anyway, the child means very happy to see that the child has recovered and is running around. Okay, thank you.
Thank you, madam.
Happy to hear that because we expected a malignancy. I expected the first moment it will be going to be a malignancy. At the end, happy ending. Thank you. Ajisha,
Thank
you
you,
did.
sir. Thank you.
Thank you. We'll wind up. What does it?
Wind up.
Thank you.
Latika end or vote of thanks in
ഞാനല്ല സർ, ഞാൻ വേറെ കോർഡിനേറ്റർ അല്ലേ. വളരെ ഭയങ്കര ഇൻട്രസ്റ്റിംഗ് ആയിരുന്നു കേസ്. എന്തായാലും
മാഡം
താങ്ക് യു. അതുകൊണ്ടാണ് ഞാൻ ആദ്യം പറഞ്ഞത് റെയർ കേസ് ആണ് എന്ന് പറഞ്ഞത്. അതിപ്പോൾ പറയാതെ വെച്ച് അവസാനിപ്പിച്ചത്.